exact mode of ventilation on bilevel, with the advantage of they can breathe on top of this and they can breathe on top of this, and with this inverse ratio they don't need paralysis. Okay, well, somebody can say, oh, paralysis, literature, but literature is now equivocal on paralysis. I love paralysis, by the way. It has its own advantages for at least the first day or whatever. It has its own advantages by itself, not by the mode itself, right? But what if you already had paralyzed the patient? During this hospitalization and you already paralyzed the patient, you're gonna paralyze him again, he's gonna be weak. Or what if the patient has myasthenia gravis? What if the patient has, you know, some critical care myopathy or something? You don't want to paralyze him again. This will be a great mode for you, right? So, the question now, why did we switch? So we switched this about, I think, 4 years ago. Actually, sorry, 5 years ago on the dot now. Huh? 5 years ago, we switched that everybody that comes to this ICU be on bilevel, not APRV, bilevel. And so where did that come from? Just because we want to switch, or because it's a big decision? It's not like, like we eliminated the other modes of ventilation. This is the only mode of ventilation in the ICU. We do pressure control for paralyzed patient and ARDS, and we do pressure support obviously for patients who are getting extubated, but most of the other modes are gone. So we switched for all the advantages that I've told you, and all the claims to fame, the 8 claims to fame that I've said through the whole lecture, and the sedation, and all of these things, right? But the straw that broke the camel, like the last straw, was something that we noticed, which is another claim to fame, something that we noticed on pressure control. So before we moved to this, we were a pressure control hospital. We were doing pressure control in the ICU all the time. And when we use pressure control, we typically put the patient on 1-to-1 I-to-E ratio. We don't do 2-to-1 obviously because we don't need to paralyze everybody. 1-to-1 they can tolerate without paralysis, and it's good recruitment still, right? And then at some point we noticed that the respiratory therapists are telling us that multiple patients, one after the other, they're saying that the patient did not tolerate even the SAT. Like you put him on SAT, which is a wake up, no SBT yet. He breathes in a 50, okay. So put him back on the vent. Another one, 50, another one, 50, another. So what happened? So we went to, investigated what's happening, and it turned out that there's like an inherent issue. We know about it, but it's just we didn't know that it's that, we didn't know that it's that common to happen. When you order 1-to-1 I-to-E ratio for pressure control, is there a button on the vent that says I-to-E ratio? No. The button on the vent that the respiratory therapist set is called the I time. So what they do exactly the same calculation. They say, okay, he wants 20 breaths per minute, the patient is breathing at the same rate, let's say, and 1-to-1 I-to-E ratio, so it's 1.5 seconds for inhalation. I'm gonna assume that it's 1.5 seconds here, so I'm gonna assume that the exhalation is also gonna be 1.5 seconds. No problem. What does the patient do as soon as he wakes up, when he stops the sedation? Before he even opens his eyes, he breathes faster. And when he breathes faster, he cannot take from the I time, because the I time is set as 1.5. So he had to start cutting from the E time to start the next breath. And when he starts cutting from the E time, he gets breath stacking or whatever you guys call it, but it's called auto-PEEP, or inverse ratio. And when he inverts the ratio, he gets even more agitated. So he breathes faster, becomes a vicious circle, and you never get to put him on anything. When we had a huge respiratory department, and we were doing 1 SBT a day, that wasn't a problem, because the nurse, everybody knows what time, you turn off, the respiratory therapist comes, she calls the respiratory therapist, by the time they finish the breakfast, the patient is just waking up, and then they turn the thing to SBT. Nobody noticed that. But when we started to do 2 SBTs a day, and we lost some respiratory therapists, it became, okay, I turned it off, the respiratory therapist is in CAT scan. So nobody can turn the vent into SBT. So he remains on pressure control as he is waking up, and he breathes fast, and he has this problem. So that was the straw, the last straw. We said, that's it. We're not doing that anymore. We're doing bilevel with 1-to-1 I-to-E ratio, similar waveform, and when they wake up, whenever they wake up, they breathe over this and breathe over this. They don't need to inverse the ratio. They don't need to take from this or take from this. They just breathe over that and breathe over that, and they're more comfortable. So that worked for us. But the day I was switching, I was scared. I was very, very, very scared. Why? Because I could kill patients with this mode of ventilation, and then they're gonna say, he switched to this mode of ventilation, and that's what resulted. So for example, let's say Professor Wild West came in with her usual, heroin overdose. She did a little bit more this time. So she needs to be intubated. So she got intubated for air protection. Her lungs are perfect. Professor Buttigieg comes in and is like, oh, it's my first day in Brockton. I know that Cal likes this mode. So let's put him on that mode, what is it called? APRV. Put her on APRV. The respiratory therapist wants to be helpful, so he knows that you don't know anything about APRV, so he said, okay, I'll put her on APRV for you. So he put her on 6 seconds high time, 35 high pressure, 0.5 low time, and 5 low pressure. APRV. So what would happen to Professor Wild West? No, she'll breathe.
Blood pressure. My lungs are fine.
And your lungs are fine. What's gonna happen? You will die. I don't care about the barotrauma. We can correct that. You will die. You will have a cardiac arrest.
Is the venous return?
Huh?
The venous return will drop?
Yes, the venous return. So basically, if you put somebody on this mode that has normal lungs, all of the pressure inside the alveoli is transmitted directly into the vessels. So no venous return for 6 seconds. And then you allow her to have a venous return for 0.5 seconds, so a little bit blood comes out, and then you go back again up. And so then she drops the blood pressure, and everybody, septic shock! Let's line her up, and it's not septic shock. It's just her lungs are healthy, and her heart is empty. And then within like minutes, maybe an hour, she'll have a cardiac arrest, right? Unless we flood her with fluid and do something else, right? But, so that's dangerous. Luckily, obviously, when we use this mode, this ARDS patient, no pressure is transmitted anywhere. They don't even drop their blood pressure because of the how much the lung is stiff, right? So I want to use bilevel on you, but he made a mistake and said APRV, so that's why I'm so scared, right? So I was so scared, so that's why we have to continue to combat the culture of interchangeably talking about these two modes. Every time I see a nurse that says APRV, I say bilevel. She rolls her eyes at me. I say bilevel again. Next time she says APRV, I say bilevel. Until they change, until they call it bilevel, right? Because if you call it APRV, a mistake can happen. Another mistake can happen, which is, let's say I'm still with more than 1 second bilevel, low time, right? Right? Mm-hmm. But the high time is 9 seconds. Still the same thing is going to happen to a lesser extent, right? There is a good venous return during the 1 second, 1 second and a half, but the majority, I'm giving 12 seconds on the high pressure and 1.5 seconds. Also, that's dangerous. I don't want my patients to have that. So we made a lie. We lied to everybody, and we said that you cannot have bilevel unless the 2 times are equal. So that's the rule. I abide by it all the time. No bilevel is done unless the 2 times are equal. So as I'm going up, 35 of pressure for 5 seconds, no venous return, I'm giving you another 5 seconds of a huge amount of venous return, right? So at least the venous return is not gonna be affected in somebody who doesn't have lung disease, or very minimal lung disease, right? So that's why you see we start at 2 and 2, and then go to 4 and 4, 6 and 6, 8 and 8. We never go the other way around. And then, of course, another hindrance to starting this process is to say, how do people, like, when you graduated from medical school and went to the first shift and they said, hey, what do you want to put this patient on? Coming from the ER or something, or you're in the ER, intubated, what do you want to put the patient on? Volume control 512, 5 people and 100%, like easy. You can spit it out easily. Here, if you don't know the settings and if it's like not ingrained in you're not gonna do it, right? So in order to encourage people to do it, we made a kind of a song or something, 28822. So it's always in your head, 28,822, 28,822, 28,822. And if you forgot that, they know it so much, just say the usual. And they're gonna put it on 28,822, right? Is that so far away from what we were using before? No. It's actually, when we were using pressure control, typically we would use 20. And for like 16 years, I've never gone anybody on PEEP less than 8, because PEEP decreases the incidence of VAP, unless obviously there's pneumothorax or something, but in general, I then never go less than 8. And the rate usually is 14, and it's 1-to-1 I to E ratio. This is 1-to-1 I to E ratio, and the rate is 15, so it's the same thing. So we didn't change anything from what we were starting people on, and we're starting here. But to our great surprise, good surprise, is that we found that the gases on this is much better than the gases on this, even though they're the same, right? And that's, I hope one day I'll finish that study. That it's a study that will that is basically designed or the hypothesis of the study is to say that the APRV in an equivalent minute ventilation will give you more alkalosis, more towards alkalosis, more more ventilation in an equivalent minute ventilation. Like you give me 5 here and 5 here, that 5 here is more valuable than this, and that's what we noticed. The most common gas. Have you noticed the most common gas in Brockton ICU is what? Maybe you didn't notice.